are in low and middle class countries, and greatest impact is on the people who are 40 to 60 years of age. While most of the people, like 50%, are asymptomatic whenever we are talking about type 2 diabetes. And if you see this graphically, how this is increasing in all the part of the worlds. So either 2 times or 2.5, more than 2.5 fold will be increasing in Asia and Australia. So if we start now, the diabetes is a metabolic syndrome. It is characterized by hyperglycemia resulting from either the defect in insulin secretion, insulin action, or both. And basically, it is the lack of insulin, or we are unable to use insulin properly, which leads to diabetes. The basic background for diabetes type 2 is the genetic predisposition. And top of it is, the sedentary lifestyle. But what is the microvascular level or microcellular level in which the diabetes is developing is the defect in mitochondrial fat oxidation, and it is the excessive intake of the energy, khana pina hamara zyada ho gaya, and which leads to increased fat in the fat cells and increased muscle and liver, which will be causing insulin resistance. And that will be causing some inflammatory markers for the fat cells, leading to resistance, and ultimately that leads to diabetes mellitus. So this is what is the simple mechanism when we talk about diabetes mellitus. And this is the natural history of diabetes type 2, which is again just confirming that before the diagnosis of diabetes, people are harboring the macrovascular complication. And this is important that whenever we are diagnosed with type 2 diabetes, we are very happy. But at that time, about 50% of the people, they don't have the beta cell functioning. And almost 50% people will be harboring the macrovascular complications. So this is the key point when we talk about management of diabetes. And if we see the relation between atherosclerosis, diabetes, and insulin resistance, so if you take in account all the factors like hypertension, obesity, hyperinsulinemia, diabetes mellitus, dyslipidemia, and particularly this small dense LDL, inflammation, hypercoagulability, all leads to atherosclerosis. And the potential risk for diabetic complication is in the form of the macrovascular or microvascular. And it is basically the endothelial function which is disturbed and which leads to both microvascular and macrovascular complication. And when we talk about the cardiovascular risk, it is definitely increased 2 to 4-fold mortality. And diabetes is responsible for about 25% of the cardiac surgeries, and mortality in diabetes is there, and it is 70% due to cardiovascular disease, and 2.5-fold increase in stroke because of diabetes. If we take the cardiovascular triad, this is just what we are having the background when we're talking about the management. If this triad is coronary artery disease, peripheral vascular disease, and cerebral vascular accident. And if you take one by one, the angina, silent ischemia, mitral infarction, sudden cardiac death, and heart failure, these are the coronary artery disease. And when we talk about the cerebral vascular accident, it may be TIA, it may be complete stroke, it may be dementia. And when we talk about peripheral vascular disease, it may be simply foot ulcer. Before that, it may be intermittent claudication. And ultimately, what we are seeing across the board that the gangrene is there in most of the cases, and it is one of the major cause of the amputation of below the knee. Again, the same is that how these factors are interacting with each other, in which diabetes is leading to atherosclerosis, which again goes into the cardiovascular complications. Yes. So this is the key point actually, that in diabetes, it is endothelial dysfunction, which will be leading to vascular tone, impairment of the vascular mechanism, and impairment of the nitric oxide production. And the platelet aggregation also there, or activation is there, so leads to increased plasma fibrinogen, increased platelet aggregation, and decreased fibrinolytic activity. And third one is the plaque character, in which the greater amount of lipid-rich atheroma is there, increased macrophage infiltration and activation is there. So this is the basic mechanism which should be addressed whenever we are talking about diabetes and cardiovascular complication. And over here is the inhibition of protective factors in diabetes. The glucose and lipid metabolites, what they are doing, they are inhibiting the factors which are very important or protective in cardiovascular system. That is the anti-inflammatory factors, antioxidant factors, insulin, and other factors. So if these are inhibited, then it means the vascular injury will be there. So with this, now if you come to clinical risk factors, everybody knows that these risk factors are either modifiable or non-modifiable. So the factors which are non-modifiable, we cannot do anything. We should be just thinking. So these are the factors which we cannot do anything. So what are those? It is the age. Higher the age, more the risk. Gender, male is at higher risk. If there is a family history in premature development of cardiovascular disease, then it is more prone to have this cardiovascular complication. And it is again in African American, the risk is very high. And now if you take in account the modifiable, which are in our hand, in which we can do something, we can be putting ourselves for the management of patient, and that is the hypertension, hyperglycemia, top of it, dyslipidemia, physical inactivity, unhealthy diet, and smoking with obesity. So if we take in account these factors which are right now in front of us, we can decrease the prevalence, incidence, and the complication of cardiovascular complication in diabetes type 2. So again, I must be going back that risk factors which are not modified and the risk factor which can be modified. So with this, if we just come directly to the management, it is always multifactorial. No doubt, control of hyperglycemia is very important, which we'll be seeing in our coming slide. But I give it an equal position. It is equally important to control blood pressure, to have lifestyle modification, to have platelet stabilization, and control the dyslipidemia, which is in the form of triglyceridemia and people with dense, low particle like LDL. And now if you just see this, you might have seen many a times. But actual impact is that if we decrease 1% HbA1c, it can lead to 12 to 43% decrease in the complications, which are in the form of either the microvascular complication or in the form of the macrovascular complication. So again, keep in mind, only 1% will lead to have this impact. Now, when we are talking about Sitagliptin and Metformin, a role in these complications, first of all, I'll talk about Sitagliptin. Just Sitagliptin is a group of incretin-based therapies. What these are doing, not only decreasing the hyperglycemia, decreasing the weight, myocardial injury, endothelial dysfunction, blood pressure, and dyslipidemia. So this may be the GLP-1 or incretin-based therapy. Now, if you see the Sitagliptin mechanism, just a food which is going in the form of glucose will be leading to release of GLP and GIP in response to an increased concentration of glucose in digestive tract. And rapidly it has been taken by the DPP4, which rapidly decreases, just see over here, and by decrement, there is an incretin effect for a very short time. But when we are applying these DPP4 inhibitor in the form of Sitagliptin, we are having the same number almost, and we can potentiate the incretin effect, which will lead to what? The insulin release, glucagon decrement. So, this is the mechanism which is there as far as the molecular mechanism is concerned. But what sitagliptin theoretically doing actually? What sitagliptin is theoretically doing, which is a DP4 inhibitor? So, just check 4 things. It is causing anti-inflammation. It is an antioxidant. It is decreasing lipid accumulation. It is the anti-apoptosis, accelerating the level of the beta cells. So all these mechanisms, if we are taking in account, we can well imagine that it may be affecting atherosclerosis, which ultimately lead to cardiovascular complications and increasing mortality and morbidity. So now we will be discussing what are the different trials. These are the very, very known trials which were there when WHO asked to have the cardiovascular protection or by the drugs. So these are the drugs which were tried, and these trials showed. These trials were showing that these are not increasing, these DPP4 inhibitors are not increasing the cardiovascular mortality or morbidity. These are having neutral effect. I'll be taking the sitagliptin. This is a well-renowned trial, which is by the name of the TCOS, which has shown that the hospitalization for angina is decreased. Fatal and non-fatal MI is decreased by 5%. Fatal and non-fatal stroke is 3%, while the hospitalization is non-inferior to placebo. So this is the impact of the sitagliptin as far as the cardiovascular morbidity and mortality is concerned. And just to see the combination of sitagliptin and metformin, just see one, that if this HbA1c is less than 8, then decrement in HbA1c is 0.1. But if you come down, that if the HbA1c is more than 11% on the baseline, the decrement is 3.6%. When 1% is decreasing so much cardiovascular morbidity and mortality and the complication, what the impact of this 3.6 will be there? And if you see the next one, that with the help of simple sitagliptin, the metformin 1000, sitagliptin 550, and if we are using this 50 and 1000 BD, then the impact is 2.9%. So alone is having different effect, and the combination is having more impact. So this is what the literature is saying. And if you just see again the control, you just see it. Less than 8%, the impact is like that, just 1%. And if you go, the higher the value, the higher is the decrement in HbA1c. And again, we must be recalling this slide which was showing that with 1% decrement in HbA1c will be causing decrement in complication from 12 to 43%. So now we come to the second drug, which is the metformin. Metformin has been used for many, many decades, and one of the very good drugs, still number one, whenever we talk about the pharmacotherapy. Whenever we talk after lifestyle, it is the first one. It is the first one. So it is having its own mechanism of action, and this is the multiple action which is shown over here. But what actually it is causing? It is enhancing the sensitivity, increasing improvement in the glycemia, improvement in fibrinolysis, improvement in microcirculation, improvement in insulin function and weight regulation. So that's how it is improving. And it is having effect by decreasing the hyperglycemia, AG formation, oxidative stress, atherogenesis, and dyslipidemia. So these two, decreasing on the right one and the increasing the left one, will be having the cardioprotective benefits. So if you just again see the sitagliptin on one side, what it is having antioxidant and inflammatory effect, and on the other hand, the metformin, which is having these much effect, though it is theoretically, but these are been proved in many of the studies, and many of these are the randomized control trials. Now, again, the complementary effect of sitagliptin and metformin. You see it. This is a placebo. What we're talking on the GLP-1. If metformin will be having this one, sitagliptin will be having this one. So these are increment looking like. But when we are having the combination, the impact goes to that, which means it can have some impact on the GLP-1 as well. Theoretic, though it is theoretically, but it will be proving the others, the trials which are coming will be proving it, that how much it will be having impact on the GLP-1 in reducing the cardiovascular mortality. So this is again a well-known trial, UKPDS trial, showing how the metformin is reducing the risk. If you see again, the diabetes death 42% and all-cause mortality 36%. So all things are decreasing right from stroke to the cardiac deaths or diabetes-related deaths. And again, this trial and the studies are there in the form of UKPDS or others are showing that in myocardial infarction, in fatal myocardial infarction stroke, the metformin is showing 39%, 41%, and 50% reduction, while the sitagliptin is showing the 3% and 5%. So next is again, if you see it separately, that metformin will be decreasing triglyceride to this level, LDL to this level, increasing HDL to this level, and the sitagliptin in comparison to the glimepiride will be decreasing cholesterol total like that, triglyceride like that, LDL like that. So it means that these both are exerting beneficial effect on glycemia and the lipid profile, providing pleiotropic effect in inhibiting the cardiovascular events. So this is again the trial, not only the hyperglycemia, but the result of this study, which is again from Southeast Asia, suggests that action of DPP inhibitor improve not only glycemic control, but also blood pressure, lipid profile, and quality of life. So it means that sitagliptin is a sound agent for use in comprehensive treatment of patients with type 2 diabetes. This is a spike trial. This is important again, that this is on the intimal thickening of the major vessel. Sitagliptin preventive study of the Intima-Media thickness evaluation, which is showing that sitagliptin treatment still attenuated the progression of mean intimal thickening of the common carotid artery and left maximum intimal thickening of the common carotid artery compared with the conventional therapy. And this is again another data showing that there is a favorable effect of DPP-4 inhibitors treatment on carotid atherosclerosis in patients with diabetes. And if you see over here, it was showing the intimal thickening. Over here, it is showing the atherosclerosis. It means they are both complementing each other. And this is another study which is showing that the use of sitagliptin in type 2 diabetes with recent acute myocardial infarction was not associated with increased risk or of any adverse cardiovascular risk. So it is again very evident from these comparison. And this is again a very important retrospective 5-year follow-up cohort conducted in type 2 diabetes, showing that coronary heart disease risk reduction 28%, stroke risk reduction 28%, and all-cause mortality 33% with heart failure mortality reduction in 21%. So this was a big study, 49,000 people were included in that, and this was a retrospective 5-year follow-up was there. And if you see this, again see it, that glycometabolic intervention as an adjunct therapy to primary cutaneous intervention in ST-elevated myocardial infarction, 250 patient randomized control trial showing that it leads to that it leads to, the metformin leads to relative improvement in left ventricular ejection fraction of 52% of the people compared to placebo, and it was reducing the infarct size by 22%. With this, if you see the Prestos trial, again showing it is a retrospective analysis showing metformin in diabetes undergoing coronary intervention appears to decrease adverse clinical events, particularly death, myocardial infarction, as compared to the people who were not given the non-sensitizer. And this is again see from here and over here. So with this, if you see, it can be the ideal therapy for treatment. These are the characteristics. You just go back in these in back slides, that the drug which is decreasing the HbA1c, the drug which is decreasing the resistance, the drug which is decreasing the hepatic glucose production, the drug therapy which is increasing the preservation of beta cell mass, drugs which are not causing weight gain, and the drugs that are not causing hypoglycemia risk, and the drugs which are not increasing the cardiovascular risk. So this is the characteristic of an ideal therapy. And if you just review what we had discussed up till now, it looks that these two drugs individually are having impact on a molecular basis, on atherosclerosis, and in combination, these are having a clinical impact, which is in betterment of management of people with diabetes. So if I take just one or two slides again, that metformin is efficacy is high, 1 to 2% reduction in HbA1c. In this, we are seeing in a scenario of what we have discussed, the ideal. Hypoglycemia neutral, weight loss is neutral. Some people say it is loss, but basically it is neutral. Renal, previously it was contraindicated in renal failure. People were not given in 1.4 creatinine, but now it is the GFR which is referred there. And if it is less than 30, then you should not be giving it. Otherwise, it is neutral to progression of diabetic kidney disease. GI side effects are there, but if they are more, we may be using the or 19 and 20, that cardiovascular disease possible benefit, and it is because of the impact on lipid profile, and the first line treatment of diabetes and heart failure should include metformin and SGLT2 inhibitors. 2020 cardiology online, what are the guidelines are there? ACC guidelines are there, again showing the SGLT2 inhibitors as far as the cardiovascular protective effect is concerned. It is bone neutral, nothing causing, not causing osteoporosis, and it is not causing ketoacidosis. So this is the ideal which we had discussed in this. And if we talk about the DPP4 inhibitor, which we are discussing right now, the Sitagliptin. So if you see with this scenario of first slide, that efficacy is moderate, 0.5 to 0.7, very correct. Hypoglycemia is neutral, and the weight gain is not there, rather it is neutral. It is effective in reducing albuminuria dosage only in not in lingagliptin, but other drugs which may be needed, and GI adverse effects are not there. In heart failure, what is there? The Saxa and algogliptin may have the risk for the heart failure, but not with the Sita like in the TICO studies, and it can affect atherosclerotic cardiovascular disease. Possible benefit is to benefit on the lipid that previously discussed. It is not causing osteoporosis, and it is not causing ketoacidosis. So with the bag of data and the ideal therapy, ideal drug, if you just have a look on these two drugs, it looks to be that these will be decreasing the morbidity, mortality in people with diabetes, which is more concerned with cardiovascular events. And conclusion, I will be just giving that the most of the morbidity and mortality in type 2 comes from cardiovascular events, and we should address three key areas in management of diabetes with type 2. One is, this is important again, screening for type 2 in patients with all high-risk cardiovascular disease, aggressively treating cardiovascular risk factors, which are modifiable, which I have already discussed, incorporating new glucose-lowering agent with evidence for improving cardiovascular outcome into routine practice. So thank you very much for attending this talk in today.